And David, congrats on your grant that I heard about. What I mean, I sent you a little note about that, and congratulations. You haven't received it yet, but in any event, what was that grant all about? That sounded pretty interesting.
Yeah, it's a CFI infrastructure
Yeah.
on virtual care,
Yeah.
which we put in a year ago, which is obviously like a world of a difference in virtual care. But it's to build a virtual care laboratory for different clinical areas. So there's a surgical piece, and then there's a mental health piece and primary care. But it's now it's both incredibly relevant and also a little bit dated, just because of all the movement that's happened over the last 6 months. It's quite amazing.
But you were prescient to think about this before the pandemic, thinking about a virtual world in which to look after patients and see patients. That's amazing.
Yeah, you know, this is something we started working on about 4 or 5 years ago. And there was like so little interest and uptake in sort of the influencers. It just now, you know, some just have to wait for the timing to be right.
That's fantastic. Great.
Congratulations, David. That's excellent. That's excellent news.
Thanks, Dana.
If you need, I've got a couple residents and new faculty who are interested in this space. If you need collaborators or people whom you want to work with and stuff, there's one new faculty, Vahag Nikolai, who's just started at OHSU with Sean Orenstein, who is trying to put together a collaborative around virtual care. I know he would love or thrive from your mentorship and help if you don't mind me connecting you, even if just for some advice on how to do it.
For sure. It's been 20 years since I've been to OHSU. So hopefully I'd love to go back at some point. When we
there you go. See, we can always find reasons for all of that.
Okay, so for folks just joining the line, we're about to start the Robert McLeod lectureship this year. We'll just give it another minute or two, and then I'll introduce the lectureship, and I'll turn it over then to Natalie to introduce our guest speaker, and we hope that you enjoy this presentation today. Just another minute or two. Yeah, Natalie was just saying she's put in a multi-million-dollar grant for CIHR, and deadline. When did you push? Did you push the button, or is that coming soon?
Oh, we pushed. Victoria and I pushed the button last night at 7:40, so just about 12 hours ago. That's it.
So it's really time to celebrate this morning. That's
that's right.
That's the best feeling when it's in and it's off your plate and there's nothing else you can do. What was your grant on, Natalie?
It's about engaging patients more in care and having them help determine the outcomes that are important for them, and then allowing them to get this information back out of our rich data sources in Ontario.
It's wonderful.
Okay, so I'm just going to share my screen with folks, and then we'll begin. Okay, so hopefully everybody can see that. And it gives me great pleasure to introduce this year's Robert McLeod lectureship. And the format for today will be that I'll be introducing the lectureship itself. I'll ask Natalie Coburn, who organized the event today, to introduce our guest speaker, Dr. Dana Telem, who's here from University of Michigan. And then we'll take questions at the end. Please, if you have questions as the lectureship is carrying on, you can introduce those into the chat line or Q&A line. I'd be happy to take those at the end. So a little bit about Robert McLeod, dear colleague and friend, and graduate of the University of Alberta for medical school, U of T for general surgery, and then did a fellowship at Cleveland Clinic. But she was ahead of her time in studying clinical epidemiology at McMaster University, way ahead of her time, light years, you would say, because she then took that as her major academic thrust for decades to follow. She became a staff surgeon at Toronto General Surgeon, Mount Sinai's, and professor in the Department of Surgery. She's a vice chair currently of the quality and best practices in the Department of Surgery, recipient of numerous awards that are listed there: Lister Prize, James Forth Society Fellowship, Charles Tatter Surgeon Scientist Mentoring Award. She had previously been a regent of the American College of Surgeons Board, American Surgical Association chair, especially of the membership committee, past president of the Canadian Association of General Surgeons, president of the Society of Surgery of Alimentary Tract, and I really want to underscore her being the current president of the American Surgical Association, which is a major coup, I think, for a Canadian surgeon. And so, Robin, again, congratulations for that honor. Over 350 peer-reviewed publications, and grant capture steady and consistent over 30 years. Here she is winning the Lifetime Achievement Award in the Department of Surgery. I had the honor of handing this award to her, presenting her with the Levina Lickley Award just last year. But one of the legacy pieces that Robin no questionably has left with us in the Department of Surgery is her devotion to best practices and quality, the whole quality agenda and movement. And that morphed into, from general surgery into best practices in all of surgery now, as you know. And she's written all these guidelines with her members of this very important group. Some of the more important recent ones include pain management, small bowel obstruction, and so many other really important guidelines. So, and there's a newsletter that comes out many times each year. So with that, I'll turn the podium back now to Natalie, who will introduce Dana for us. Natalie.
Great. So I'm really pleased to invite Dr. Telem to speak with us today. She's a surgeon at the University of Michigan. She is currently interim chief of the Division of General Surgery and serves as our vice chair of quality and patient safety. She also is a director of the Michigan Women's Surgical Collaborative. She has an extensive amount of training. She did her surgical training at Mount Sinai in New York, and then minimally invasive fellowship at the Mass General, and then returned to Columbia University for her Master's of Public Health. She works on a number of initiatives, and I think she really does a lot of work that's very similar to what we've been doing in Ontario, and that's one of the reasons we wanted to hear about what she's doing in Michigan. So she looks at large data sets to look at the outcomes, and then looks at why surgeons are doing certain things with their outcomes and why not. And so a lot of what she's began to examine is kind of the science of how surgeons think, why they do certain things, and how we can work within those confines to improve outcomes. Right now, she's serving as in key leadership positions, such as the Board of Governors for SAGES and the Foundations for Surgical Fellowships Board in the United States, and serves as on the editorial board of Annals of Surgery and Surgery for Obesity and Related Diseases. She's been very kind and has met with a number of our faculty over the past few weeks so that we can get to know her. It's obviously a bit of a difficult thing to come and be a visiting professor in the middle of a pandemic, but she's done this very graciously and really spent a lot of time with us. She's going to spend some time with the residents and SSTP students right after this lecture. So without any further ado, I will let her go ahead and give her a talk. Thank you.
Thank you so much for the kind introduction and for the kindness that everyone has shown. While it is sad, of course, that we can't be in person, it's been really wonderful getting to see friends and make new friends this week with being able to meet many of you. And I can tell you that there is really no greater honor than to be invited to give this lecture in the name of Dr. McLeod, who's been a pioneer for, I think, all of us in health services research and quality improvement, and a role model in this area. So thank you so much for this invitation. So I'm just going to share my screen here and we'll get started. So the title of my talk today is really about the science of changing clinical practice and culture, which I hope that I can make a really great argument are related. These are my disclosures. I will tell you that these first 4 grants are directly related to the work that we're doing around clinical practice change. And this last grant, while not directly related to the work, is similar in terms of addressing issues of inequity and achievement. So I want to start off with kind of what the big picture is and why do we think that this is related. The way that I think about my practice or my research efforts and the way that I approach problems is sort of in this pattern, which is, what is the gap that we're trying to solve, and who really needs to do what differently, and how can we create the sustainable behavior change that we need to see, whether that relates to clinical practice, where I'm going to use hernia disease as an example of work, or whether that applies to culture change, which really addresses inequities in advancement and achievement for persons of color as well as women in surgery. And so the question really starts with, how can you create the sustainable behavior change that you need to address the practice gaps that you're looking to address? Because as we all know, we can create as many evidence-based recommendations as we'd like. However, when we go to enact them into practice, particularly in the United States, which is a multi-payer system, what ends up happening is more often than not, they fall short. There have been numerous publications demonstrating at least a 10 to 17-year gap between the release of an evidence-based practice and adoption. So I think we really have to start asking why. And when we think about behavior change, I think the most important part to think about is the level of intervention that you need. So where I'm going to start in practice change is at the individual. And the reason why I'm starting at the individual level for hernia disease is because that's where the decision to operate occurs. For many of us who have benign practices, we don't have the benefit of tumor boards or multidisciplinary conferences to really discuss patient care. And whether or not we decide to operate on a patient, really that locus of control rests with that individual surgeon. So understanding what drives those decisions is really what the key to practice change is. So I always start this, well, why should we really care about hernia, and why is hernia an important condition to study? And while we're studying hernia, I also want to put this in the context that hernia is a preference-sensitive discretionary condition, much like some of orthopedics and joint replacement or back surgery. So it's really kind of a quintessential example of where we can have really optimal outcomes. But for hernia specifically, it's very common. It impacts 1.6 million people are diagnosed with a new hernia every year. We do over 500,000 operations. It's costly. Complications related to hernia disease cost our healthcare system about $3.2 billion each year, and it's morbid. I think that this is a little bit deceptive because oftentimes we think hernia, oh, it's no big deal, we'll get it fixed. However, I will say up to 1 in 4 or 1 in 5 persons who undergo this operation in an elective setting will go on to have an adverse event that will negatively impact the quality of their life. And so what are our current challenges? I think the biggest challenges, at least that we have in the States, is around nomenclature and coding, meaning that a lot of the large data sets of administrative data where we use operative codes, or CPT codes, or ICD-9 to extract data are very difficult and discriminating types of hernias that have very, very different outcomes. So the same CPT code or the same code that we would extract from a data set could mean this tiny little 1 to 2 centimeter umbilical hernia to this large, abdominal wall defect, to even something like this that has a peristomal, component, and it makes it really difficult when you don't know what you're actually comparing. And so where we do have clinically nuanced data with really great national efforts, we have a lack of population level data because our only kind of clinical registry that we have in the States that captures nuanced information is surgeon initiated data. And also we really have a lack of long-term outcomes because, as one would imagine, we don't measure the success or failure of this operation in 30-day clips, right? It's really whether or not that patient's quality of life is improved and that hernia remains repaired 1, 3, 5, 10, 15 years down the line. So how do we address this? We always say in hernia disease, the holy grail is really to select the right operation for the right person and the right time. And when I break that down in my head and think about how do we figure that out, it comes down to really 3 questions of who should we be operating on, when should we do that operation, and what operation we do. And I want to make the argument that while we spend a lot of time, looking at the perioperative period and perhaps postoperative period with, things like failure to rescue in terms of improving outcomes, most of these questions that likely impact outcomes really settle on that preoperative decision. And I think that this is really an underexplored area to really pull the lever on quality improvement. So let's start with who should we operate on, because I think out of all of those questions, this is an area where we have the most robust data. As all of us know who do operations, when patients come in, they have modifiable versus non-modifiable risk factors, right? There are certain things we can't do. If somebody's older, we can't modify other aspects such as race or gender or things that may co-locate with complication. However, there is an element of modifiable things that we can intervene on prior to surgery that will improve risk. Some of those things have been relatively well documented. that impact outcomes for hernia repair and are considered relative contraindications are diabetes with poor glycemic control, obesity, smoking, and substance abuse. So the first question that we asked of our state is, what are we doing? So while we're a multi-payer system in the US, I'm very fortunate to be in a state that almost in some ways behaves as a single payer system, in that we have statewide collaboratives, which are consortiums of 70 hospitals that have all agreed to quality improvement and enter data into registries. These are funded by an individual insurance product because that is the dominant insurer in the state. So most of the work that I'm going to show you leverages data from this collaborative, the Michigan Surgical Quality Collaborative, and then some from our Michigan Value Collaborative, which is, again, a statewide sort of claims data, but also population level. So what we saw when we kind of turned the mirror and looked at our own population is that for persons undergoing abdominal wall hernia repair, 25% had at least one contraindication at the time of elective surgery. So you may ask yourself, well, okay, but there's a certain element of decision making. Perhaps it's not that big of a deal. Did this translate, to worse outcomes? And what we saw is when we looked is that it did translate to worse outcomes, meaning that for persons with one of these comorbid conditions, there was an increased risk for complication, discharge not to home, such as a subacute rehab facility, emergency department utilization, and 30-day readmission. And when we evaluate what the cost of that to the state is, we saw that there were increased episode of care payments on the order of $60 million related solely to hernia-related complications in the state. So then we came up with our first goal. So our practice gap is that we know what we're supposed to do, and we are not doing it across the state. So our goal is to optimize patients prior to surgery. And we set, stretch goals for us, meaning the modifiable factors that we believe that a body mass index should be below 35 or 40 at the time of surgery, to demonstrate smoking cessation at least 4 to 6 weeks preoperatively, and A1C levels from 8. And we have the data to support that adhering to this would decrease complications as well as episode of care spending, so our outcome metrics that we can look at. The next question we asked is, well, is this a couple bad actors that are skewing the data, or is this sort of pervasive? And what we then looked at is aggregate variation and adherence to preoperative optimization across sites. And you can see here that there's a pretty wide distribution by site. However, even in our best performers, we still have 20% of non-adherence, suggesting that there's room for improvement. And so the next step is we knew we had a problem and we had quantitative data to support there was a problem. However, the question we asked is why? Why are surgeons not adhering to evidence-based practice? Because you could imagine that the intervention for somebody who simply doesn't know that this is what they're supposed to do versus somebody who doesn't want to do it are going to be very different. And so we went around and we spoke to many practicing surgeons that were practicing within our Michigan Surgical Quality Collaborative across the state, made sure to have pretty good variation and a heterogeneous sample of different practice patterns, different lengths and times in practice. And what we really found was that there were 3 barriers as to why people weren't optimizing patients prior to surgery. First was a financial barrier. And to put it simply, we don't get paid not to operate. And a concern of loss of income, whether due to the case alone or loss of referrals because you're saying no to your referring provider, or reputational damage from a patient going online and bad-mouthing you and then just simply getting the repair done by a competitor down the street, were really big barriers to being able to do this. Second were issues related to knowledge and resource access. And when I say that, I don't mean that persons didn't know that preoperative optimization was important. What they didn't know is what were the elements, infrastructure needed, and what was available to them if their hospitals did not have an optimization program. So you can imagine Michigan is a wide state with very, very different practice patterns. And sometimes persons in smaller community settings don't have access to things like an endocrinologist or a dietitian in the same way we do in our academic centers. And here there was also a lack of knowledge around statewide resources to help programs. And finally, it was really around practice patterns and organizational barriers, meaning there was a malalignment between what an individual surgeon wanted to do and what their organization or what their practice expected from them. And of course, also within that is clinician autonomy, where some persons just really felt that their practice was so different that they had to make every single decision as an individual. So once we had that data, what do you do with this qualitative information? And I think this is where you want to really marry and think about how do you put that quantitative and qualitative data together to really come up with theory-based multi-level strategies aimed at addressing each of these barriers. When we initiated our interview framework, we did this along something called the theoretical domains framework. And what this is an implementation science framework that marries these different barriers into domains, and these domains map to evidence-based behavior change techniques. And when we set up our initial interview guide, each one of our questions were aligned with one of these domains. So then we went through and we were able to code it. We could marry that to those strategies or to those behavior change techniques that would be most impactful, depending on what we found. And so when we married our barrier attributes to these domains and sources of behaviors, we then found the intervention functions that would be most likely to change behavior and develop theory-based strategies. And this seems kind of like an easy jump, like A goes to B, but I'll tell you, coming up with which strategies to use was a complex process that really required a large literature review, what's historically worked well in the MSQC, what would work well in partnership with our insurance providers, and really what made sense with variable surgeon practice. And we had multiple meetings with various stakeholders across the state, ranging with surgeons and abstractors, to really kind of inform which strategies would work best. And at the end of the day, we came down to 3 multi-level strategies. The first was a financial strategy. And in the US, we use something called pay for performance metric, which is supposed to incentivize value-based care. And what we did was I took this information and we went to our insurance provider, which is Blue Cross Blue Shield, and we presented it. And it was funny, just to add a little anecdote or quip, that I went with one of my mentors, Michael Inglesby, and he turned around and said to me that this is the first time he'd ever seen any value in any type of qualitative research, because what really pushed the envelope here were those individual surgeon quotes and patient behaviors, which really motivated the burning platform that we needed to address this. And so essentially what we have is a hospital or organization level incentive that's meant to reward good decision-making. And this strategy is a little different than what's typically used, because most of our pay for performance strategies reward outcomes, and this one rewards process. And we thought that this made a little bit more sense when trying to influence decision-making. The second strategy we use is a clinician-led educational strategies. Now, educational strategies are oft used to try to change practice behavior. And really what it's doing is leveraging and trying to put together all of the things somebody needs to know to be successful. Now, the Achilles heel and the crux of any educational strategy is the methodology in which communication is disseminated, as well as the ability to assess whether knowledge was transferred. And what we did here is spend a lot of time thinking about the delivery of this educational strategy. And to do that, we found an electronic dashboard for modular-based learning. And within these learning modules, we're going to leverage opinion leaders to create a sense of urgency, as well as overcome some of the practice conformity issues we found, education on the statewide resources and how to deploy them, and also addressing patient-facing barriers, because as many of you may know, this preoperative period is really a teachable moment for patients, where they are able or willing or more motivated than they would be otherwise to perhaps make the changes that they want to make in order to have the perioperative barrier. And we wanted to make sure not to lose this opportunity and help our clinicians understand how to do this in an optimal way. The final strategy we use is on-site facilitation. And this one is really meant to align clinicians and organizational leaders or practice leaders. And what it's meant to do is really enhance strategic thinking and leadership skills and enable cultivation of provider champions to overcome the barriers to adoption. Now, I think the first question you have is when we see 3-level strategies is, will this work? So pay for performance we have used numerous times through the collaborative, and really is one of the standards in which we do care. I think the other 2 strategies, we wanted to get an idea of what that looks like in implementation. So we started doing a pilot program across 2 sites. And we did this through a hernia optimization program through clinician education. We spent a fair amount of time educating our clinicians on the importance of optimization, and there are 7 people across these 2 sites. And then we created an optimization clinic by which patients would be kind of extracted from the surgical consult initial visit and placed into this separate office visit in order to try to optimize or do the things we need to do to delay a surgery until we could mitigate those preoperative risk factors. This program has been ongoing for about a year and a half. At last check, we went through about 165 patients, and you can see the distributions here. And so what did we find? We had 3 questions when we started doing this. One, is this efficacious? So we put people through this program, and about 10% ended up graduating and going on to surgery. And I think you can argue whether or not that's efficacious. 10% certainly doesn't sound like a great number, but when you compare it to the general surgical population of who does it on their own, it's about double, but there's certainly room for improvement there, and something that we're looking into in terms of the why didn't other patients go on to be successful? The second question we had before deploying something like this or making recommendations like this is, it's safe. For any of us who take any type of emergent care, I think we all know our biggest fear is that patient we say no to in the clinic shows up at 2 or 3 o'clock in the morning with an incarcerated hernia and poor outcomes. And what we found is that this is relatively safe. One of the things that we have in Michigan is an electronic medical record, which allows us to track any healthcare utilization across the state. And we found among persons entered in this program, which are arguably some of the highest risk people, only about 3% or a little under 3% ended up in an emergency department with a hernia-related complication. And the last question is cost effective? And this is really based on kind of American utilization of cost. It was, and I can go through this a little bit later, however, essentially by substituting patients, we changed what the surgeon clinic looked like, which ended up increasing the operative yield per clinic, which ended up with a net financial benefit while providing efficacious and safe care to the persons who needed it. So when we then went and looked at our implementation outcomes, we found that our clinician-led training alone, just kind of educating persons along these modular pathway, increased our referral for preoperative optimization pretty significantly. And it also increased adherence to evidence-based guidelines by about 11%, and the cost to do this per patient was approximately $7. When we added our on-site facilitator, which was really a person who ran that preoperative optimization clinic, we found that this increased referral to 29% for sort of rehabilitation exercises, increased adherence to evidence-based guidelines an additional 6%, but the cost for this facilitation is clearly more than $7. It was approximately $10,000 based on a full-time equivalent over a 1-year period. So what's next? So one of the great things about being in this laboratory is that we have a chance to test this out. And what you're looking at here right now is a SMART trial design. A SMART is essentially a randomized control trial, which recognizes the trade-offs between resources and costs and attempts to create tailor-made intervention, because we all know that not all hospitals will require all strategies. And there are trade-offs, with cost of something that's $10,000 versus $7 versus nothing if a hospital is going to be successful with a low-resourced cost for intervention at baseline. And essentially what the plan here to do is in fiscal year 21 is deploy that financial incentive across our statewide collaborative, see how people do over a year, exclude sites that have a complete response, which is pretty rare, so we don't anticipate that to be more than 10 sites, and then randomize sites that have a heterogeneous response to this financial incentive to either remain the same or to augment with that clinician-led training program, where they're going to follow them out another year to look for responders versus non-responders. Those that respond to the P4P alone will continue that. Those that don't respond will be re-randomized to either continue that financial incentive or step up and really clinician-led training. And for down here, those that were randomized to receive clinician-led training, responders will continue on that alone, and non-responders will be re-randomized, and again, to continue that alone just to see if more time will help, or stepped up for on-site facilitation. So the next question we have is sort of what operation should we do? And I really think that this is the Achilles heel of hernia repair. And here it's really because we have really limited clinically nuanced data. Kind of like the picture I showed you earlier, it's really hard to understand outcomes when you don't know if you're comparing a 1 centimeter defect to a 10 centimeter or 15 or 25 centimeter person with loss of domain. We have one initiative in the US, the AHSQC, now called the ACHQC. And this has been a really wonderful initiative led by Ben Pelos and Mike Rosen, looking at can we capture these data? And so what we see here is we do have some clinically nuanced elements. However, there is, I think, some selection bias or confirmation bias in that this is all surgeon-entered data. So this entire registry of about 71,000 patients is based on the entries of 446 surgeons across the country. And one could argue that surgeons who would self-select to enter their own data into a registry are probably those who are bent on quality improvement anyway, and may exclude persons within the population whom we don't understand that practice. So what we did sort of in collaboration has decided to augment our Michigan Surgical Quality Collaborative with population clinically nuanced data. And so in February of 2020, I was able to add variables that are going to help us discern and discriminate between various types of hernias so that we know how to compare apples to apples. And these variables really include hernia location, previous hernia repair, hernia length and width, the mesh used, the type of mesh, the brand of mesh, how it was fixed, whether or not there was a myofascial release and sort of that type of release. And this is just kind of meant as a shock and awe campaign. I don't expect anybody to look at these tables, but we just queried the data set for our early results, and we have about 526 complete data sets. And I was shocked at the amount of technical variation that occurred. Even for a 2-centimeter hernia, you have persons who range from doing a simple primary repair to a component separation, which I think underscores the need for quality improvement and investigation into this topic. And so what are some of the barriers that we're facing? I think our main barrier is really on missingness and data missing. As anybody who fixes hernia, and perhaps this is different in Canada than it is in the States, I oftentimes, given that hernia is a chronic and relapsing disease, will get off notes that essentially say, there was a hole and we fixed the hole and we placed mesh. And sometimes that's not super helpful because you kind of want to know, well, where was the hole and how big was the hole and how was it fixed and where's the mesh? And so we kind of had a two-pronged intervention. One is the development and deployment of synoptic operative notes across the state to help standardize communication, not just to reduce missingness, but to help our colleagues understand when hernias recur, what happened. And two, through stakeholder engagement, meaning talking to all of our data abstractors, nurses, clinicians, and trying to get buy-in and excitement about this project. And so we initiated this at 8 pilot sites, and a lot of this work was actually done by Leah Delaney, who's a medical student with me and just a fantastic, brilliant person who will be applying for residency next year. And what we saw was that in the sites that we deployed the synoptic op note, much lower levels of missingness and in sites that we didn't. And so we were all excited. We thought our intervention worked. And then we went to talk to the sites and found out that actually none of them had been using our synoptic operative notes. But why there was so much engagement was we had spent so much time with the data abstractors that they were completely had buy-in on this project and were so excited about it that they were calling the surgeons when there was any data missing and kind of hounding them until they made sure that their operative notes were correct. And I thought this was a really good example of how you think one intervention works, but it turns out it was something completely different, even though you have the right result. So future directions, again, it's marrying all this data to really understand how to provide precision care for our persons with hernia disease. Long-term clinical outcomes, again, this is something that we're going to really have to work on. I think even in our best laid registries, 1-year data tends to be where things start falling apart. And then long-term quality of life outcomes, because arguably this surgery is to improve quality of life. And I can tell you that we do have some early data from 90 days out of hernia repair that suggest 1 in 10 persons who undergo a hernia repair have an element of regret. And regret is a little bit different than satisfaction because regret really measures surgeon decision-making. So we clearly have some opportunity to improve here and really understand what we're telling our patients. This is our team. None of this can be done alone. And I really just want to recognize these residents, Leah and Ryan, who really helped kind of get all of this work done. Sarah Jaffrey, who's a medical student, and Quentin through all of this. So I know this is going to seem kind of weird, but I kind of want to switch gears here. And so what I just showed you is an example of how we can use behavior change to change individual clinical practice. And now I want to talk about how we leverage kind of sustained behavior change to change organizations and systems and address practice gaps for something different. And one of these areas that are sort of near and dear to everything that I believe in is really mitigating inequities and achievement. I don't think it'll be any surprise to anybody on this meeting that we have pervasive issues of inequity for academic advancement of women. And you can see that over time, these have been relatively flat with very little bit of improvement. This is AAMC data comparing 5-year trends in academic advancement for women for all persons, not just for surgeons. When we drill down to surgery, however, we see these same, if not exacerbated or exaggerated, achievement gaps. And the first question people will ask, is this a pipeline problem? Well, no, we go to our quantitative data and we say, is there a gap here? And what we see is that there's really near parity in medical school. And in the States, at least, there's near parity in general surgery. So it doesn't seem that we can explain this achievement gap, solely as a pipeline problem, at least for white women. And we can talk about persons of color or other underrepresented minorities in a second. Well, and then the next thing that we hear, well, is this just an issue of demographic inertia, meaning that we just need some time for people to catch up and for these things to happen, and then everybody's going to get there. And so when we look at the data and we do the math, it turns out that it's not. And at the rate that we're going, despite near parity, it would still take almost 100 years to have parity in academic advancement and achievement for women in surgery. So we have a clear problem. And the other issue that we have when we talk about many of these things is that we talk about women as monolithic or men as monolithic, and we don't really leverage the intersectionality or the different areas of things that make us us, that make our struggles, barriers, and other opportunities very different. And what I just want to point out is that we do have perpetuated issues with persons of color, namely that this is a little bit of a pipeline problem, so something we need to think about a little bit different for underrepresented minority surgeons in academic surgery. This was back in 2008, as well as issues around career experiences for Black and African American academic surgeons and women, where these have been perpetuated even when you look across persons in the same race and ethnicity categories. So I think the question is why does this remain? And now it comes down to sort of the fact finding is why do we behave? Why is the system set the way that it does? There have been numerous studies suggesting motivators and drivers of gender inequities, such as differences in mentorship and sponsorship, differences in work-life integration issues, differences in academic opportunities, expectations around gender norms, implicit and explicit bias, as well as other things. One of the first things that we did as an organization, though, and we'll talk about the Michigan Women's Surgical Collaborative in a moment, is we really, again, wanted to turn the mirror on us, on our department, and really ask, well, what are we doing right and what are we doing wrong? And we were able to interview women from our department who had left and who were still here to really understand what the barriers and facilitators to advancement for women in academic surgery were. And then we published it. And so I'll have to say that Dr. Dimmick and Dr. Mulholland, who was our chair sort of at the time, who acknowledged and let us publish this, are really pioneers for this work, because I don't know how many chairs would kind of let you publish very openly and very publicly some of the dirty laundry that you uncover for the guise of quality improvement. And what we found through this series of interviews is that it's not the person, right? A lot of times people say, oh, well, she didn't want to do that because she had a baby and she wants to go home, or there's other competing priorities. It's really not the person who doesn't want the achievement. It's really the organizational culture and policies that affect opportunities for advancement. And so in that respect, we know where our decision node is. Instead of the individual surgeon who's making decisions, it seems like it's our organization and system that's making decisions for us by not allowing equitable opportunities. So anybody who studies quality improvement knows Edward Deming, which is every system is perfectly designed to get the results it gets. And so it's our job to change the system. And our job is to create an environment that equitably recruits and retains all persons, and to create an environment where all can be successful. And this was our burning platform. And I want to talk about the intervention strategy that we did in the local level. So the Michigan Promise, I hope people are familiar with, but if not, it's meant to be a relentless faculty development tool to make sure that faculty of all phenotypes can be successful at the University of Michigan. This is a starting point and not a finish line. And just a little bit about how this intervention started was that this was a ground up and top down initiative, meaning that there was impetus to change at the organizational leadership and people who are willing to roll up their sleeves and do the work. I would say Dr. Mulholland sort of started this initiative, and over here you can see Erica Newman and Jen Walge, who led us through it, and then Dr. Dimmick and Dr. Dossett, who catapulted it to the next generation. And so let's start with the first thing that we really intervened on, which is recruitment. Because if you can't recruit the best candidates and you can't recruit phenotypically diverse candidates, then your institution and your department is going to know is not going to change. And what the barriers here are is that there's sometimes implicit bias in evaluating numerous critical but subjective attributes and reliance on a small trusted network for developing an applicant pool. I think all of us know sometimes hiring works, your graduating fellowship, your boss or your mentor calls on your behalf. There's kind of a backroom handshake deal, and then that job does. But when we do things like that, it sort of perpetuates us finding people like us because that's whom we tend to like. And that's the implicit bias that occurs. And so what we did, or really under the lead of Erica Newman, is that we really revolutionized how we recruit persons. There's no more picking up a phone and calling somebody. We recruit broadly, we advertise widely, we bring people in and ask objective evaluation and behavioral attribute-based questions. And we build national partnerships to make sure that we have an applicant pool that is diverse. When you come in, you don't just kind of meet with a couple people. Every single applicant that comes in will come in. Well, and it used to be, I guess, prior to COVID, now it'll be an online Zoom. You meet with this recruitment committee, which is made up of 10 to 15 faculty, various phenotypes of research, rank, and ability. And you sit here and everybody asks you questions, and that way every single person in that room hears what you have to say and can interpret and discuss. And I really think that while it looks like it's something that could be intimidating, is very much appreciated by applicants because they feel they were heard and they feel that they had an equitable opportunity for that job. Second is environment. The environment obviously is king. Culture is king. And if you don't have the right culture, you can have all the best intents, but it's not going to move forward. So for one of the things that we're done is a culture crew, and these are people that are dedicated to improving workplace culture and environment. Some of the working groups and initiatives that are being undertaken is a mission and objective, a Walls Do Talk, cultural complications, culture assessment, and then bystander training and response. The Walls Do Talk initiative is an initiative to diversify our walls and essentially represent all phenotypes of faculty and kind of what motivates them. And this is really to get at sometimes our walls are filled with a very monolithic view of the history of surgery. And we wanted this to be dynamic and represent our next generation. Next is cultural complications. I think that Dr. Dossett, Dr. Harris, and Dr. Dimmick came and shared this with you. This has been extraordinarily impactful in terms of normalizing discussions around implicit bias in a non-confrontational, non-judgmental, and non-personal way. And it's really been interesting and exciting to see how this has evolved from cases that were kind of preemptively done to ones that are now being brought based on real life experiences. And it's really evolved. And I think that we do this monthly now and is just kind of a crowning jewel of our morbidity and mortality conferences. Another part of our environment is I would call peer mentorship and support. This is our Michigan Women's Surgical Collaborative, which I founded and have the privilege of participating in with these women. And what this group is meant to do is not only rigorously study systems level strategies to help mitigate that achievement gap, but to help disseminate those to others. And we do this through the form of national meetings. You can imagine that was a little bit hard in COVID this year, but we were able to conduct a series of webinars to help support, understand, and address additional barriers that persons were experiencing due to COVID-19. And actually, I'm super excited to have about a manuscript with strategies to overcome some of the perpetuated achievement gaps that we are submitting shortly with strategies for institutions to consider implementing to overcome some of those barriers. Next is an achievement. You know, I talked a little bit about inequities in mentorship and sponsorship, and I think all of us rise or fall by those who are lifting us up. And what these teams were meant to do, mentorship teams, overcome reliance on a single person. And every new faculty that comes in is assigned a team based on their academic and clinical interests in order to help them be as successful as possible. We just started launching boost teams also because the vulnerable time period is not only when someone is an early professor, but really at that transition from early to associate professor where we see a big drop off. As well as where those inequities start perpetuating. And what these boost teams are meant to do is to help kind of exactly what it says, boost or kickstart, and help phenotyping and goal setting, trajectory mapping, and making sure that people have the sponsorship that they need in that delicate transition to make sure that they're successful. And finally, leadership, which is a cornerstone. We have many leadership development programs. Here's an example of the one that we have in 2020. which is really about coaching, culture building, leading change. These are disseminated not just at the faculty level, but our resident level as well, to try to help everybody understand what are those key attributes and skills necessary to be successful to lead high functioning teams to get high functioning performance. And this is also evidenced in our early career faculty exchange programs, where we help give leadership opportunities and exposure for people that are coming from our institution, as well as giving equal opportunity to many of the universities that you see down here, to allow our young faculty to network with others and then to network with the young faculty across, to build a network of peer mentorship. And this has been extraordinarily well received. And here are just the persons that have participated in our early career faculty exchange program. I think some of them are getting battlefield and otherwise promotions, early promotions just due to excellence. I'm not sure we'll be able to call some of them early career anymore, but just phenomenal opportunities and feedback from this program. So at the end of the day, I hope that I have convinced everybody that understanding motivations and behaviors is the key to bridging the gap between evidence-based practice and the sustainable behavior change that's needed to both change clinical practice and culture change. And that really the only difference is the level of the intervention, but that we can use our same HSR techniques to address sort of all of these problems and barriers that are facing us, regardless of which domain in surgery. So with that, I'll say thank you, and I'm happy to entertain any questions that you may have.
Okay, fantastic. I think there's a lot to discuss. I'm going to start with a question that's in the chat room, and it's a hernia question. So the question is, are you familiar with, and can you comment on the process and outcomes of the Schuldeis Clinic, which is here in Toronto? And maybe how does that differ from what you've studied?
Yeah, and so I think the Schuldeis Clinic is a great example of a clinic that's bent on quality improvement. They do one operation, they do it extraordinarily well. They well select their patients, and their outcomes are really great. And I think for low risk patients with a small inguinal hernia, that is a fantastic example of how you can get great outcomes when you kind of just deal in that one area. I think the question is how does that change or expand if you have persons with larger hernias, higher risk patients? Would those outcomes sort of be the same? And so I applaud that clinic for their dedication to quality improvement and for really mastering one technique. However, the way that I kind of think about these quality improvements are sort of in those larger, more broad base of how are we addressing those really vulnerable populations that have had 3, 4, 5, 6 operations, because that's where most of the morbidity occurs.
Next question is, it's brilliant that you found a practical and educational, non-threatening intervention to do what is in part to do to a huge ethical conflict for surgeons, which is financial incentives. Do you think that this is generalizable to other disease areas? And how does this work in different areas? I think the financial payer relationship in Michigan is very different than it is in Ontario and Canada and the rest of the country. So I'll tag on my part of the question to this one. How's the payer situation different there? And how do you leverage these payer situations to fix the ethical considerations?
So I think you hit the crux of the problem. I mean, that's, I think an Achilles heel of all of this. So let me start with sort of the financial incentive. Pay for performance is oft used across the country, and I'm going to throw all my work under the bus, which is we know that there's been little data to support improvement based on pay for performance incentives alone, which is why that heterogeneity, I think, is really important to address with sort of practical strategies. Because I think if we just rely on a payment incentive or alternatively a disincentive, we're not going to get the practice change we want to see, namely because it's still very much a fee-for-service system. And then when you try to scale it external to other areas of the country where there's multi-payer, there's not sort of that same buy-in unless, of course, we can get governmental support through CMS or our Medicaid and Medicare insurers. I think, that tension between payment versus practice, and what I think is, and this might be very naive, so forgive me, I think that for the most part, for most surgeons want to do the right thing. Surgeons want to do the right operation and not hurt somebody or potentially set them up. And it's probably a minority of bad actors that no matter what you do are not going to change their behavior. One of the questions that we often get is incentives versus disincentives, right? The carrot versus the stick. We tend to use incentives because our collaboratives are not mandated. They are agreements for quality improvement. And you can imagine that the more prescriptive and draconian that you get, the less that people may want to kind of participate this. And the goal for this isn't to exclude or to parent people or to tell people what to do, but to generate interest in coming together to get the best care. This notion of paying surgeons not to operate is sort of where I think we're trying to move to. And when I say not operate, what I mean is delay surgical intervention until we can mitigate the factors that we know will help people. Now, I think that there's two examples of this. One, this can be leveraged, I think, across many procedures that can be delayed, right? Sometimes various orthopedic, back surgery, hand surgery, you know, sometimes even hysterectomy. Any preference sensitive discretionary operation that's not time sensitive, you could apply this to. And I think one area where we've seen this done relatively well is bariatric surgery, right? There's a million financial disincentives to kind of get a patient through to bariatric surgery, which is really, really painful and in some ways limit access to surgery for persons who need it most. But on the flip side, we have worked together as a society to make outcomes of that operation nearly the safest of any operation, right? Every surgery, every person going through bariatric surgery isn't somehow rehabilitated. They're looked at from a psychological perspective. They're looked at from a nutritional optimization perspective. They're optimized from a medical perspective. And because of that, we've taken an operation which on the surface should have a tremendously high complication rate and did in its initiation because you are operating on very high risk, morbidly obese persons with multiple comorbid conditions and made it safer than a gallbladder removal. So I think there's a way to change behavior with incentives and with buy-in and with collaboration, even across different payment systems, because we managed to do this for bariatric surgery. The question is how to do this in a way that doesn't disincentivize or add additional barriers that limit access for vulnerable populations or patients who may need this operation, you know, in spite of some of the comorbid and risk factors.
Okay. I want to practice choosing questions. So this question is, do you have any tips or thoughts on motivating senior, well-respected, established academic surgeons to have them make changes that won't directly benefit them?
Well, I think all efforts start sort of at the ground up, but there also has to be impetus for change. And so that's kind of why I bring up when people ask about the Michigan promises, how did you get this through, right? There was a desire for change, and the second that door was open, the floodgates opened and everybody was like, let's do this, and went through. I think part of getting change, if there's zero impetus for change at the top and there's going to be zero support for it, that's going to be really, really hard. If there's support for it, I think you have the opportunity to, one, do a gap analysis. What do you need? What do you need to do differently? What are the specific questions that you're trying to answer and want to do? And then find an advocate, an opinion leader, and an influencer that may have that person's ear and help you sell that narrative of why this is important. Include everybody. Most importantly, the people who don't want you to do the work, invite them, have them come sit at the table to do the work with you and tell them why, and have them tell you why none of it's going to work. And that way, once they feel included and heard, I think that you have a little bit more chance of doing it. So, you know, oftentimes it's about influence, opinion leaders, learning how to manage up and including the people who are going to be the most resistant, which will help get the change done.
All right, the next question is a story and then a question. So my doctor diagnosed me with a hernia. He recommended a surgeon at his hospital. And I said, well, what about the Schuldeis Clinic? Well, that would be fine, he said. Well, where would you go, I asked. And the Schuldeis Clinic is what he replied. So I think this speaks to the financial incentives, but it also speaks to the local networks, which I think are part of the EDI, part of your talk. So how do we get physicians or academic centers to do what's best rather than referring locally or pulling locally from your talent pool?
So I think that has to do with knowing what's best. And while I respect, like I said, I'm not here to throw anybody under the bus. I respect the outcomes of the Schuldeis Clinic. I think we also have to ask questions of, you know, in 2020 and 2021, what is the best repair for an inguinal hernia? Is it an open repair? Is it a MIS or a minimally invasive repair, whether laparoscopic or robotic? Is it, does it matter by the surgeon or what technique? Because I would argue, you know, the Schuldeis clinic may or may not be about the technique, but just, you know, that virtuoso 10,000 hour practice that they have great results because they do one thing and that one thing does well because they do it in well-selected patients. But that doesn't mean that that's the right thing, right? Like that person might get just as great care going to somebody who offers a minimally invasive therapy. So we often say the best technique is the one that's done by the surgeon with the, you know, ability to do those. And I think a lot of that drills down to figuring out, well, what is that right technique for that person? And if it's a Schuldeis repair, then that person should go to the Schuldeis clinic. If it's a minimally invasive repair, then that person may not benefit and may actually have a detrimental outcome by going to the Schuldeis clinic. So I think it really has to do with kind of closing down and getting to that precision of knowing how to recommend a procedure based on individual and patient-specific factors.
So the next question is, shouldn't the question actually be, how do we make all hospitals have as good a results as the Schuldeis? And I think this is something we've struggled with within Cancer Care Ontario, is what is the barrier to collecting the data, giving the data back, and how do you strike that balance? Because I know in some situations, the governmental agencies have been worried of offending or disenfranchising certain groups of people. How do you make that balance?
I think people want to see their data, and I think data is a powerful motivator. When you see your data and you are an outlier, I think that there is probably no more powerful emotion than wanting to figure out how you can make yourself not an outlier and put yourself back, because I do hold the firm belief that surgeons do not want to hurt people, and they do not want to be the person that's on the other end of that confidence interval that's having higher complications. And again, with the Schuldeis clinic, you know, if we could all pick perfect, you know, great patient selection, but some people we don't have the luxury. And I think this is really where understanding variations in practice and having robust risk adjustment and being able to compare, you know, similar patients across practices and how they're performing, you know, is really very important to make sure that those robust risk adjustments are accounting for variations in patient populations too. But data are powerful techniques.
Dana, I wonder if I could ask you a question about the second part of your talk and really about equities. And congratulations on your work with the Michigan Promise. That's fantastic. Wonder how will you measure success in that program in terms of diversity, and over what time period do you think that will play out with your implemented changes?
Yeah, for sure. So, you know, there's kind of the early successes and later successes, because we're not going to really know what the final impact of a program like this, both at an organizational or national level, is for at least 5 or 10 years down the line. Developing, sponsoring, promoting takes a while. It's not something that's going to be overnight. Our initial outcomes are really more implementation outcomes: feasibility, acceptability, impact. Are people, you know, when people vote with their feet, you know what I mean? Like, are people participating in their programs? What's their experience been like? Are we able to do this? Are we garnering partners? And I'll tell you, it's been extraordinarily well received. And right now we have a network or partnership with 10 other institutions who are implementing elements of it. So right now we're just kind of looking at early outcomes. But I think the longer term outcomes are really going to be 5 to 10 years down the line. Again, looking, did we mitigate that gap that we had in advancement from assistant to associate or associate to professors between women and men and other persons whom we hired? What does the complement of our faculty look like? I can tell you, even in the 3 years, or I've been here 4 years, but in the 3 years since we've been doing this recruitment process, our faculty already looks very, very different. And I'm not talking just from a race ethnicity standpoint, I'm talking from a phenotype perspective. It used to be an academic surgeon was one who did basic science and did lots of things. And right now we have people who are studying global medicine, education, research, translational. Like, even in 4 years, anecdotally, our section in our department looks much different. So I can't give you basic numbers yet, but I can tell you we're seeing a big difference.
Great.
I'll wrap this up. Dr. Telem, thank you so much for the talk and for joining us today, and for meeting with the residents next. And I will turn this back over to Dr. Rutka.
Yeah, so thanks, folks. And Dana, again, thank you very much for a wonderful Robin McLeod lectureship. Thank you, Natalie, for organizing this. Folks, as this is the last time we may see each other virtually like this, you get to see the holiday season card first in the Department of Surgery. We put this together obviously because of the world in which we live right now. And I think a lot of us are a little fatigued by what we see on the screens all the time. On the other hand, it gave us an opportunity to wish you all a very safe, healthy, and happy holiday season. So all the best to you. We'll look forward to seeing you in 2021. Thanks again.
Thank you so much. And I look forward to
Dana.
meeting with the residents in a few minutes.
Okay, bye-bye, folks.